Good evening, everyone. Today's speaker is Dr. Sandeep Tilwani. He is DM neonatologist and working as a consultant neonatologist in the Norway Hospital in Vellore. And his area of interest are infectious control in the NICU, also the nursing care in NICU, and various other aspects. So today's topic is neonatal shock, and it is really a pleasure for us that Sandeep is willing to take this session for our resident and other faculty members. Thank you, Sandeep. So without wasting time, you can start.
Thank you, ma'am, for the introduction. I'm very happy to be able to interact with others. I think after a long time, it is almost 3 months. So, yeah, is my PPT visible?
Yes, his screen is visible.
Okay, yeah. So I think I will start. Yeah. So, good evening. As you all know, the topic for today is neonatal shock. So again, it is actually a very broad topic. It is something if I go step by step, it may take even I would say 4 or 5 hours. Okay, so my job is to cut down the lecture to 1 hour. Okay, maximum 1 hour. So I will try to cover all the basic aspects, and at the same time I would try not to confuse you too much, because in 1 hour if I keep on bombarding so many concepts, it will disturb you. So I mean, I'm basically targeting the residents. So I mean, I try to simplify it as much as possible. I think my three and Parth are here, so many of the things they will be able to relate which we were doing in our management of shock when I was there. So I'll just start with the management and basic concepts of shock. Okay, so the overview for today's talk is, first I'll be discussing in brief about the cardiovascular physiology. Okay, and second is something about the transitional hemodynamics and the peculiarities of a preterm cardiovascular system. Then next we'll be discussing the definition of shock. What are these various stages of shock? What is the etiology of shock in newborns? What is the pathophysiology? What is the clinical diagnosis and the challenges associated with uh, uh, shock? And last would be the management, which are the current best practices for management. Okay, so moving ahead, the first part is the cardiovascular physiology. So, I mean, since first year of our MBBS, we have been learning all these topics. But the problem is, when it comes to managing a patient on the bedside, many times we forget the basic simple physiology. Okay, so what basically, I mean, the entire cardiovascular system, its whole and sole purpose is, if I put it very simply, if you take your cardiovascular system in a simple sentence, it is nothing but a delivery system. Okay, it acts to deliver oxygen and nutrients to the tissues so as to meet their regional metabolic needs, and at the same time, its other role is to remove the carbon dioxide and other metabolic waste from the tissues. Okay, so this is actually the main role of the cardiovascular system. Okay, and for moving the oxygen and nutrients from the heart to the tissues, we need a force. Okay, so this force, which is responsible for movement of blood, and along with that, oxygen and nutrients from the heart to the tissues, is actually the blood pressure. Okay, so it is the blood pressure which is actually the driving force from the heart to the tissues. Okay, it is the blood pressure which is responsible for the movement of oxygen and nutrients. Okay. So, I mean, as I said, the whole purpose of the cardiovascular system is to deliver oxygen to the tissues. So that delivery of oxygen, how much oxygen is actually going to the tissues and how much it is actually delivered to the tissues, it depends on two factors. First is how much is the oxygen content of the blood, and second is how much is the cardiac output. Okay. So putting it simply, it depends on two things. कि एक तो आउटपुट कितना है, कितना ब्लड हार्ट में से निकल रहा है, एंड सेकेंड वो जो ब्लड हार्ट में से निकल रहा है उसमें ऑक्सीजन कंटेंट कितना है. Okay, so the oxygen content, again, it depends on two factors. First is your hemoglobin content of the blood. Okay, तो blood में oxygen कितना है, that will depend on कि भाई blood में hemoglobin कितना है, because ultimately it is the hemoglobin which is binding with 99% of your oxygen. So blood में hemoglobin कितना है? Second is वो जो hemoglobin which is present in the blood, of that how much is actually saturated with oxygen, okay, which is something when you see when you are monitoring the SpO2. Your SpO2 is nothing but the percentage of hemoglobin which is saturated with oxygen, okay. And the cardiac output in turn depends upon the stroke volume and the heart rate. So this is basic physiology जो हम फर्स्ट ईयर MBBS में पढ़ते थे, right? So, as I have shown here, your blood pressure is nothing but it is a product of, or it is directly proportional to your cardiac output and the systemic vascular resistance. Now, the systemic vascular resistance is nothing but the pressure which is exerted by the arterioles. Okay, जो tissues में छोटे छोटे arterioles होंगे, capillaries होंगी. So the resistance which the blood has to face when it is moving through these small arterioles or capillaries, that resistance is your systemic vascular resistance. Okay, so your blood pressure is actually nothing but a product of cardiac output, means how much your heart is actually pumping and how much resistance the blood has to face. Okay, so again, your cardiac output, as I said before, it is a product of heart rate and stroke volume, and your systemic vascular resistance, it depends upon various neuroendocrine and paracrine regulatory mechanisms. And again, we have read in physiology that your stroke volume depends again on three things, that is your preload, afterload, and the cardiac contractility. Okay. So these are actually the last column just shows the abnormalities which may affect each of these, right? So, so far, I think it would be clear that it is your blood pressure which is the driving force, and this in turn depends upon how much is the cardiac output and how much is the systemic vascular resistance. So, I mean, as I said, the entire thing depends upon the blood pressure, or blood pressure is actually the driving pressure for oxygen. So again, the blood pressure has got many different components, right? We have learned in first year physiology, okay, there is something called a systolic blood pressure, there is something called a diastolic blood pressure, there is something called a pulse pressure, there is something called a mean blood pressure. Okay, so which of these is important in which aspect we'll see. So first, coming to the diastolic blood pressure, it is actually nothing but the baseline pressure which is exhibited by the elastic recoil of the great arteries. Okay, that is your aorta, pulmonary artery, जो major vessels हैं, उनका baseline elastic recoil and the vascular tone of the arterioles which are present in the tissues. Okay, so these are the two things which are responsible for your diastolic BP. Okay, so ultimately your systemic vascular resistance and the intravascular volume. Okay, that is how much blood is actually present in the system, that, and secondly systemic vascular resistance. These are the two things which would determine your diastolic BP. Then coming to the pulse pressure, as we all know, it is nothing but your difference between the systolic and the diastolic pressure. Okay, so what happens is the baseline pressure in the cardiovascular system is the diastolic pressure. On top of it, जैसे ही your myocardium contracts, it sends out a volume of blood into the peripheral vascular system. Okay, so that volume of blood which is ejected from the heart, it exerts certain pressure above the baseline. So baseline is your diastolic pressure, peak is the systolic pressure, and the difference which actually occurs as a result of myocardial contraction is nothing but the pulse pressure. Okay, so basically baseline pressure जो है हमारे cardiovascular system में, that is a diastolic BP. जो peak pressure है, that is the systolic, and जो peak pressure होता है, that is actually because of your volume of blood which is coming out from the heart. So that is nothing but your pulse pressure. Okay. So, I mean, of all the components, the systolic BP, mean BP, diastolic BP, in newborns, as far as newborns are concerned, the systolic BP and mean BP, they are not very reliable at times. Why? Because newborns, the cardiovascular system is not very simple. I'll tell you why. There is presence of shunting in the newborn period. Okay, in the immediate newborn period, especially, what happens is कि PDA open होगा, there is opening of the patent foramen ovale. So there is mixing of the right and the left heart circulations going on through this PDA and PFO and other intrapulmonary shunts. So as a result, your systolic and mean BP, they are to some extent affected by these shunts, whereas your diastolic BP and the pulse pressure are relatively less affected by the presence of these shunts. Okay, so that shows that we have to rely more on your diastolic. Coming to the this thing, that why does BP actually matter? I mean, why I have spent around 10 minutes on this BP thing is because there is something called auto-regulation. Auto-regulation means what? As the name suggests, ठीक है? Auto-regulation means खुद से regulate करना. So what happens in this auto-regulatory concept is कि uh, blood pressure, it does not depend only on the blood flow. Okay, कई बार क्या होगा कि due to some reason, कोई suppose कोई particular रीजन की वजह से योर बीपी इज कमिंग डाउन, बट दैट बीपी कमिंग डाउन डज नॉट मीन कि भाई योर ऑर्गन परफ्यूजन विल बी impaired. Body has some compensatory mechanism to maintain the BP initially. Okay, so that compensatory mechanism is the auto-regulation concept. Okay, so during a temporary period of instability, the first response is nothing but there is auto-regulation. Auto-regulation में basically क्या होगा कि there is local organ में vasodilation होगा, and as a result there is increased blood flow and improved oxygen delivery so as to prevent hypoxic damage. Okay, and if still the oxygen requirement is more and the blood supply is low, beyond a certain point क्या होगा कि auto regulation will fail, and when the auto regulation fails, ultimately anaerobic metabolism starts and the patient enters a phase of decompensated shock. Okay, so in neonates, especially in the preterms, the main problem is कि auto regulation is functional at a very narrow range of BP. Okay, just to give an example, this auto regulation thing is there in us also. Okay, in adults also we have auto regulation which is very active. तो हमारे में क्या होता है कि the auto regulation range is very wide. So our auto regulation range is from a BP of 50 mmHg, it lasts up to 150. Okay, तो इसका मतलब क्या है कि अगर 50 से 150 के बीच में अगर हमारा BP अप या डाउन होता है, तो फॉर हमारा बॉडी हैज द कैपेसिटी टू not to get affected by that change in BP. हमारा blood supply to the brain, to heart and other vital organs will be maintained if your BP is fluctuating between these two, between 50 to 150. But उसके beyond अगर hypo या hypertension होता है, तो your end organ damage will start, your organ perfusion will start getting compromised. Okay, so that is why जब adults में if your BP shoots up to 180 190, we become afraid. क्यों? क्योंकि basically your auto regulation starts failing at that point. Okay, so newborns के साथ में problem is कि we don't have such a wide range of auto regulation. The auto regulation in newborns is very narrow range. Okay, so as a result they are very sensitive. जैसे ही थोड़ा भी ब्लड प्रेशर में फ्लक्चुएशंस होते हैं, उनका ऑर्गन परफ्यूजन गेट्स कॉम्प्रोमाइज्ड. Okay, then coming to the second part, that is transitional hemodynamics. So, I mean, the cardiovascular physiology as such is complicated. To make it more complex is the transitional hemodynamics. Okay, because everything is getting mixed up in the transitional period. Okay, it is very कुछ भी चीज ऐसा नहीं है जो प्योर है. Everything is a mix and match of something or the other. Okay, so what transitional hemodynamics is actually nothing but the transition, the hemodynamics which occurs in the baby during the first 72 hours, 48 to 72 hours, when the baby is actually transitioning from the in utero to the ex utero environment. Okay, so here this figure shows the fetal circulation. Okay, so fetal circulation में क्या होता है कि the figure which is, or the horizontal lines which are at the bottom, these are actually nothing but your placenta. ठीक है, so where I am pointing my arrow, so this is actually the placenta. तो होता क्या है कि entire blood from the placenta, it goes through the IVC and it enters into the right atrium. जो blood flow which is coming from the placenta, it enters the right atrium, and instead of going to the RV, it goes through the PF4 to the LA. Okay, and from the LA it goes into the LV. So आपका जो LV का जितना भी volume है, that is not coming from the lungs, because in your in utero circulation, lungs को blood supply नहीं होता है. It is very minimal blood is going to the lungs. Majority of the blood from the RA RV is going through the ductus arteriosus into the descending aorta, and descending aorta से वो body में जाके ultimately placenta में जाएगा. Okay, so what happens, one by one I'll this open the boxes. So oxygenated blood which is arriving from the placenta, it is preferentially directed through the PFO to the left atrium, whereas the deoxygenated blood which is coming from the upper half of the body, so this deoxygenated blood which is coming from the upper half of the body, it goes through the RA to the RV. Okay, and what happens is from the RV it enters into the pulmonary artery. So this is my pulmonary artery. but it cannot go beyond that to the lungs because there is high pulmonary vascular resistance. Okay, so because of it, whatever blood is there in the pulmonary artery through the PFO, it will through the PDA, it will go to the descending aorta. Okay, so there is presence of high pulmonary vascular resistance, but there is low systemic vascular resistance. Why? Because placenta has got very big vessels. ठीक है? If you remember the anatomy of the placenta, फर्स्ट ईयर एम्ब्रियोलॉजी में अगर हमने पढ़ा था तो सो व्हाट प्लेसेंटा एक्चुअली हैज सिंसिशियो ट्रोफोब्लास्ट. ठीक है, तो सिंसिशियो ट्रोफोब्लास्ट इज नथिंग बट दे आर इमेच्योर ब्लड वेसल्स और थिन लाइंड ब्लड वेसल्स. ओके, तो यहाँ पे वास्कुलर स्पेसेस बहुत बड़ी हैं, सो ब्लड फ्लो को रेजिस्टेंस नहीं होगा एंड द सिस्टमिक वास्कुलर रेजिस्टेंस इज एज सच वेरी लो बट द पल्मोनरी वास्कुलर रेजिस्टेंस इज हाई. Okay, and जो LV preload है, okay, the blood which is coming to the left ventricle from the LA, it is not coming from the lungs, it is mainly coming through the placenta. Okay, क्योंकि placenta से blood is coming to the RA and from RA it is going to the LA and from there it is coming to the LV. यहाँ पे lungs का role नहीं है. Okay, and the combined output comes to the descending aorta and from there it enters the placenta and gas exchange occurs at the level of placenta but not at the level of lungs. And placenta, mind you, it holds up to 50% of the blood. Okay, so एक 28 weeker 29 weeker baby जो अगर about to get delivered है, so keep in mind first message that उसका 50% of the blood is actually there in the placenta. उसका significance क्या है, I'll tell you in these subsequent slides, but 50% of the blood of the 28-29 weeker baby is there in his placenta and not in his body. Okay, then what happens, as soon as the baby is born, you cut the umbilical cord. Okay, and now the baby has to breathe on his own. Abhi tak gas exchange was happening at the level of the placenta, now it has to happen at the level of lungs. So what happens is, as soon as the baby is born, the placenta is gone. Okay, and now the deoxygenated blood which is coming from both the upper and lower half of the body, it enters into the right atrium. अब क्योंकि राइट एट्रियम में एंटर हो रहा है, फ्रॉम देयर इट एंटर्स इनटू द आरवी and the pulmonary vascular resistance, as soon as the baby starts breathing, what happens is कि pulmonary vascular resistance starts decreasing. तो पहले जो pulmonary blood flow minimal था, अब as soon as the baby starts breathing, because of the high oxygen concentration in the air which the baby is breathing, the pulmonary blood vessels, they start to dilate and the pulmonary vascular resistance falls, and so the lungs now start getting good blood flow. Okay, and with that the RV is subjected, that is what RV is subjected to a falling afterload. Okay, because of this now there is good blood flow to the lungs. This blood which is getting oxygenated from the lungs, it comes to the left atrium through the pulmonary veins, and from the left atrium it goes to the LV, and from LV it goes into the aorta. Okay, so आपका जो LV है, LV का preload, now it is coming from the lungs and not from the placenta. Okay, and LV is subjected to high afterload because पहले यहाँ पे placenta था which was a low pressure system. Okay, placenta has got very large diameter blood vessels, so it is very easy for the blood to flow through them. Now that placenta is gone and now we are faced with supplying blood to the arterioles which are high resistance circuit. Okay, so the LV is subjected to high afterload. And as a result of this, the left ventricular pressure increases, the pressure of the left side of the heart increases, on the right side of the heart decreases, and because of this, what happens is the shunt which was happening at the level of PFO, it closes, and the shunt which was happening at the level of PDA, it gets reversed from, initially it was right to left, now it changes from left to right, and eventually it closes. Okay, so this was about the basic transitional physiology. It is a bit complicated. I think when you go through the lecture again, it will be more clearer to you. But keeping this in mind, with this also there are certain considerations in the preterms. Okay, why the preterms are more at risk of shock as compared to the term babies. Even in our NICU also, if you see, it is more of the preterms who will be on all this inotropic support rather than your term babies. Okay, so why the preterms are at higher risk? Because 50% of the blood volume, okay, as I told, their 50% of the blood volume is actually in the placenta. होता क्या है कि जैसे ही preterm baby deliver करता है, everybody of us becomes full of anxiety. Okay, and in that anxiety, what we do is फटाफट clamp कर, baby ready होनी थी, फटाफट clamp कर. Okay, and because of that फटाफट clamping, we don't allow the 50% of blood which is there in the placenta to come back to the baby, and पहला hemodynamic insult वहीं पे ही हो जाता है baby को. Okay, so the first hemodynamic insult happens as soon as you clamp the cord. उसका 50% blood volume तो उधर ही रह गया, उसको वहीं पे ही hypovolemia start हो गया, right? So that is why they tell that delayed cord clamping is the norm. If your baby is breathing, don't be worried about or a respiratory distress che, saturation nahi maintain karega, allow some time. If possible, you shift the TPs to the baby and start the baby on TPs, but don't be in a hurry to clamp the umbilical cord. Okay, allow the blood from the placenta to go back to the baby. Okay. Second is the neonatal myocardium has less contractile tissue as compared to the children and adults. Okay, so mind you, this is the neonatal myocardium. It includes both preterm and term. So normally adults mein jo myocardium hoga, that has 60% contractile tissue, whereas in your preterms it is 30%. Okay, so anyways, in your newborns it is 30%, and in preterm neonates it is even less than 30%. Okay, so their contractile tissue is very less. Third, the myocardium has relatively inefficient contractile mechanism. If the contractile tissue be less hai, on top of it, the contractile mechanism, which is dependent upon the sarcoplasmic reticulum and the intracellular calcium, that also is immature in the preterms. Fourth is there is high because of the very high heart rate. Physiologically, the preterms and the newborns, they have a higher heart rate. Because of the high heart rate, they are not able to spend much of a time in diastole. As a result, there is less time for LV filling. Okay, so left ventricular filling के लिए इतना time adequate नहीं होता है. We have a heart rate of 70, so it 70 in a minute. So there is more time for the heart to fill. But the newborns, they have a heart rate of 150, 160. So there is less time for each cardiac cycle, less time for diastolic filling. Okay. Next, there is less cardiac reserve to cope up with the changes. So what happens is, if for some reason agar hamara cardiovascular system gets disturbed, there is a myocardial reserve. Okay, there is a backup capacity हमारे cardiovascular system में या हमारे heart के पास में backup capacity होती है कि to some extent it can put up a fight. But for the newborns, especially the preterm newborns, the cardiac reserve is very less, so they cannot cope up much with the changes in the preload and afterload. Okay. Next is there is underdeveloped HPA axis. HPA axis is nothing but the hypothalamic pituitary adrenal axis. Okay, so as a result, जैसे ही कुछ भी stress होता है, stress in the form of sepsis or hypoglycemia or increased afterload, कोई भी तरीके का stress होगा, even a simple hypothermia. So any stress which happens, I mean, हमको अगर कुछ भी stress होता है तो what happens? We usually respond with tachycardia, palpitations, sweating. Okay, so our body can handle the stress, but these newborns, they cannot handle the stress because their HPA axis is underdeveloped. Okay, so any stress which happens, they tend to go in for shock because they are not able to cope up with that stress. Okay, and there is presence of shunting also in the form of PDA, PFO, or some intrapulmonary shunting, so that आपका जो blood flow which should go to the systemic circulation, instead of going to the systemic circulation, it is going to the pulmonary circulation, and there is systemic hypoperfusion. Okay, so all these 7 reasons which I listed, these 4 and the next 3, these are the reasons why our preterm babies are more at risk of shock and hypotension. Okay, so with this in mind, this was about the transitional physiology and the basic cardiovascular physiology. Next, coming to the what actually is a shock. Okay, so shock basically, definition wise, it is very simple. If you keep this diagram in mind, I think the definition is clear. Whenever there is an imbalance between the demand and supply kiska? So basically demand and supply of the oxygen and nutrients. Okay, so a physiological state which is resulting from an imbalance between the demand of oxygen and the delivery of oxygen to the tissues. Okay, so the tissues, for some reason, for some stress, they need more oxygen, but जितना उनको चाहिए उतना नहीं मिल पा रहा है. As a result, जो physiological state होता है, that is basically what we call shock. Okay, so I mean, all of us have read it in our PALS training, and I think before also, that there are 3 phases of shock. Okay, so there is one thing called a compensated phase, wherein there is redistribution of blood flow to the vital organs, and BP is maintained at the cost of increase in heart rate and contractility. Then there is a decompensated phase wherein all the compensatory mechanisms fail and ultimately your BP falls, organ blood flow decreases. And when this decompensated phase lasts for a longer period, ultimately we end up in an irreversible phase, jahan pe there is tissue hypoxia, lactic acidosis, multi-organ dysfunction, and ultimately death. Okay. So coming to the etiology, again, etiology can be varying. Okay, there can be 100,000 different causes of shock. I'll just cover the most common ones. Okay, so the etiology can be because of poor contractility, which happens due to maladaptation after the birth, or maybe because of asphyxia. Okay, whenever there is asphyxial injury to the myocardium, the contractility decreases, or perinatal depression, or a septic shock. Okay, and or dilated cardiomyopathy because of any reason. So that all will lead to poor contractility. It may be because of vasodilation, as happens in septic shock, or maybe a systemic inflammatory response. Okay, it may be because of high afterload, which happens in cases of transitional hypotension. Okay, जो मैंने अभी बताया कि भाई transitional when a newborn is transitioning from in utero to the ex utero environment, sometimes especially the preterms, they are not able to cope up with the increase in the afterload. What happens is कि placenta, which was a low resistance system, is lost, and now the baby has to pump against the high resistance systemic blood flow. So systemic this thing circulation. So as a result, there will be high afterload, and the heart is not able to cope up with that high afterload. Sometimes because of that, there may be shock. It may be because of hypovolemia. Again, hypovolemia as such is less common in the newborns. Okay, it may be hypovolemia can happen on those conditions wherever there is actual blood loss, in terms maybe whenever there is an antepartum hemorrhage or umbilical cord avulsion, or maybe the cord prolapse, which is causing cord prolapse and cord getting compressed. As a result, there is no blood supply from the placenta to the baby. That can lead to hypovolemia. Then it may be because of a diastolic dysfunction, which happens in an immature myocardium or a tension pneumothorax, okay, which is not allowing the heart to relax and to fill. Okay, and ultimately, last is because of some shunt or arrhythmias like a PDA, or some AV malformation, which is causing the shunting of blood from the systemic to the pulmonary circulation and causing hypotension. Okay. So this was about the etiology. Now coming to the pathophysiology part. So pathophysiology of shock. I mean, if the residents remember, मैं जब भी round लेता था, I always used to stress कि treat the shock based on what is the pathophysiology. So pathophysiology means you have to see, evaluate clinically and understand what is happening to the baby, and based on that you decide your management. Okay, so pathophysiology, it varies as per the etiology. Okay, it is not कि हर बच्चा जिसको शॉक है उसको सेम रीजन की वजह से शॉक हो रहा है. Okay, there may be different underlying pathophysiology based on what actually is the etiology of that. Okay, so I discussed the different scenarios of pathophysiology briefly. So first is transitional hemodynamic compromise in the preterms. Okay, so ये जो transitional hemodynamic compromise है, this does not happen in preterms who are 34, 36 week, उनमें नहीं होगा. It is mainly for the extreme preterms or very preterms. Okay, so a baby who is 30 weeker, 28 weeker, 26 weeker, उन सब babies में they are more likely to go in for a transitional hemodynamic compromise. Okay, so simply putting, they are not able to transition from the in utero to the ex utero environment. Okay, क्योंकि in utero जब होता है तो placenta is a low resistance this thing circulation, whereas बाहर आने के बाद में they have to pump against a higher systemic vascular resistance, and sometimes their myocardium is not able to cope up. Okay, so as I told, the placental circulation is a low resistance circulation, and when we remove the placenta, as soon as you clamp the cord, what you are doing is you are blocking that placental circulation. Okay, so जैसे ही आप उसको ब्लॉक करते हो, होता क्या है कि systemic vascular resistance बढ़ जाता है, and जैसे ही systemic vascular resistance बढ़ रहा है means your myocardial afterload is increasing. Along with that, what happens, जैसे मैंने पहले बोला, 50% of the blood is actually in the placenta. So you are preventing that 50% of the blood to enter into the baby, and as a result, baby का खुद का blood volume will be low, so there is reduced preload. Okay, so what happens is there is a reduced preload, there is increased afterload, On top of it, these babies already have a poor myocardial contractility, okay, for whatever reasons I have enlisted before. So there is a poor myocardial contractility, there is reduced there is reduced preload, and there is increased afterload, all three coming together. And on top of it, there is a poor vasomotor tone, which can lead to a variable systemic vascular resistance. So all of these coming together, a preterm baby, especially in extreme preterm, lands up with shock. Okay. Then coming to a second scenario where there is perinatal hypoxia or ischemia. So usually whenever there is perinatal hypoxia, ischemia, if you understand the pathophysiology of perinatal asphyxia, so there is something called a diving reflex. Diving reflex में क्या होगा कि initially जैसे ही insult होती है asphyxia की, initial stages में the blood supply to the vital organs will be maintained. The vital organs are the brain, heart, and the adrenals. But when the insult is prolonged beyond a particular point, the diving reflex also goes off, and then there is injury to the brain and to the myocardium. Okay, so myocardial insult actually happens in one-third of the babies with perinatal asphyxia, and it happens because of the reduced blood supply to the myocardium. So there is decreased LV contractility. When there is decreased LV contractility, stroke volume decreases and the blood flow to the organ decreases. Okay. Then coming to PPHN, what happens in PPHN? PPHN is something we often neglect or we don't consider in our differentials for a baby worsening. So pulmonary vascular resistance is actually very common. I mean, PPHN is something which is very common in our day-to-day practice. Wherein what happens is the pulmonary vascular resistance, जो in utero बहुत ज़्यादा था, it should actually come down as soon as the baby starts breathing. But for some reason or the other, because of problem in the transition, pulmonary vascular resistance does not come down and it remains high. Okay, and as a result of the high pulmonary vascular resistance, the pulmonary blood flow is low. Because the pulmonary blood flow is low, there is low LV filling, and because LV filling is low, LV output is low, and there is systemic hypotension. Okay, systemic hypoperfusion and systemic hypotension. On top of it, what happens is the afterload is also high. The afterload for right ventricle is very high. Because of that, the RV has increased myocardial oxygen demand, and because of that, RV failure happens. Okay, so eventually there is both LV and RV failure happening in babies with PPHN. So I'm just telling you the pathophysiology. Management I'll discuss in the, I think maybe in the second part. Okay. So then coming to the PDA, what happens in PDA, especially in preterm babies, is there is left to right shunt occurring across the ductus arteriosus. There is decreased blood flow in the descending aorta, which we call ductal steal. And because of the decreased blood flow in the descending aorta, the blood flow to the systemic circulation is low. As a result, there is reduced in the diastolic BP. Okay, so the volume of blood which should be there in the systemic circulation decreases because of the ductal steal. So there is reduced diastolic BP. On top of it, जो blood which was supposed to go to the systemic circulation, it has gone through the ductus into the pulmonary circulation, and because of which there is increased blood flow in the pulmonary circulation, increased blood flow from the pulmonaries, it comes to the LA, and from LA it goes to the LV, and so there is increased LV output. Okay, so hota kya hai, there is a reduced diastolic BP, on top of it there is a increased systolic BP, and the combination of these two leads to a wide pulse pressure, okay, which is actually what we call a diagnostic thing for PDA in the preterms. Okay, and coming to sepsis and NEC, what happens in sepsis is because of the release of cytokines, there is damage to the endothelium, and because of the damaged endothelium, there is capillary leak, there is vasodilation in the organs, there is low systemic vascular resistance leading to a reduced diastolic BP. Also, in the advanced stages, on top of the vascular damage, what happens is the toxins, the circulating toxins, they cause damage to the myocardium, and eventually the myocardial contractility also decreases. And this, in the later stages, will lead to a fall in the systolic BP. Okay, so I think for the first part, I will cover this much because I think it is only 1.5 minutes left. Maybe the management and the diagnosis I'll cover in the second part of the talk after 1 minute.
Okay.
Is it okay, ma'am?
Yes. Thank you so much, Dr. Sandeep. So next part will be covered in the next session, and also all the queries of the resident will be discussed. Okay.
Yes, yes. I'll exit this.